at SANMED are always at the forefront of organizing knowledge updating sessions and look forward for each of you to participate and have a meaningful participation in the session. And at the same time, for today's session is been moderated by Dr. Ranga Reddy, who is popularly known as Dr. Ranga across IPC specialty. So he would be moderating the session. And to precisely introduce him, Dr. Ranga Reddy is a physician, a public health specialist, and is a social entrepreneur with interest in business verticals which has high social impact. Dr. Ranga Reddy is a health policy enthusiast focused on public health, awareness, education, and training. He is committed to the improvement of patient safety in India and other low resource settings. He's, he graduated from Minsk Government of Medical Institute, Belarus, with a degree of MD General Medicine, and subsequently he did his PG diploma in management from Pondicherry University and advanced management from IESC Barcelona, Spain, with a specialization in strategy and business development. And Dr. Ranga Reddy is the founder of a founder trustee of Infection Control Academy of India, which is popularly known as IFCI, a non-profit initiative create infection prevention capacity for India and emerging countries. In recognition to his public health leadership skills, he was invited by University of Hyderabad, an institute of eminence, to impart his knowledge and experience in the capacity of honorary professor. His effort has translated into catering several long-term programs in IPC segment. He also supports several non-profit organizations in the capacity of advisor. So thank you for being the moderator for the session. And now I'll hand over the session to you. Thank you so much, Dr. Nirav Pandya, for being a speaker for the session. Thank you so much. Sir, all yours now.
Thank you very much, Mr. Ganesh, for that introduction and kind words. Uh, Colleagues, a warm welcome to all of you to the season 5 of the master class. Glad to see many of the old friends, colleagues, and I also see many of the new faces who are tuning into this very important session from all over the world. Hope you had a great festive time, and I sincerely hope that you're slowly recovering from the fatigue of non-stop COVID duties with constantly being in PPE and in complete or partial isolation. I take this opportunity at the beginning of this session 5 to salute all those COVID warriors, and many of them, as we know, are the infection preventionists who have risked their lives to save many in the world, not only in India, LMIC, but across the world. You look at any country, I think, the tremendous efforts, very sincere and committed efforts which were made by the infection preventionists has made this world a little better. And also, to come out of this COVID-19, their efforts are uh, applaudable. And also, there are no parallels probably in the history. I take this opportunity also to thank University of Hyderabad and the SANMED Healthcare for prolonging this festive season, because we had series of different festivals of various religions of the world, and now both these eminent organizations, that is University of Hyderabad and SANMED, have given us the opportunity to prolong that festive season with yet another festival, a festival of infection prevention and control knowledge sharing. It is almost 2 years since the infection prevention and control master classes are the popularly known by now, at least in the Asia, Africa, Gulf, and Latin America, as IPC master classes have started. And happy to see the kind of response it has evoked and continue to be a major event for IPC professionals in India and other countries. Several thousand people have attended or reviewed the video material or the presentations from previous sessions, all the 4 of them, and we are delighted to get a overwhelming positive feedback which has actually helped us to go ahead with yet another season. The successful past sessions have certainly raised probably the expectations and also the bar. I am sure the sessions of the current season are also going to be meeting your expectations. Delighted to welcome all of you to back to the IPC Masterclass Season 5, which is titled as Prioritizing Evidence-Based Infection Prevention Measures for Improving Quality Care. Just to set the tone for this series, now after the COVID havoc, uh, everyone probably would agree that infection prevention and control is an essential foundation for quality universal health coverage. As probably you would all know that in October 2018, all countries of the world have gathered in Astana, Kazakhstan to reaffirm and expand their commitment to prioritize, to promote, and also to protect the health and well-being of their populations. You know, since 1978, when the first time Alma Ata Declaration was done, many countries have designed health systems that improve access to quality essential services, social stability, health security, as well as having economic benefits. Having said all that, quality of health services are increasingly emphasized as an essential factor for success of our healthcare and healthcare institutions. Infection prevention and control as an evidence-based approach is core of this quality movement which I talked about in order to halt the spread of infections and also the silent pandemic, the antimicrobial resistance. IPC, if you broadly look at it, embodies all three core domains of the quality care. That is care that is safe, effective, and people centered. That is the most important thing. Because at the end of the day, it is the patient who is the most important in the whole spectrum of the healthcare provision. And definitely, it strongly supports the attainment of other key global health priorities that eventually contribute to high quality universal healthcare. I am sure you would agree with me that strong IPC capacity and programs ensure adequate preparedness and response to protect people from outbreaks. Their reinforcement is an essential pillar for recovery and health system strengthening after the shock of an epidemic like COVID 19. IPC is also complementary to and enhance, wash interventions. As we know that wash monitors infrastructure indicators, whereas IPC provides evidence of an effect on healthcare workers, their behavior, and also the patient outcomes through improved infrastructures. IPC strategies, which are aimed at reducing antimicrobial resistance, are particularly effective due to the synergy, which they have. Combining both of them, that is IPC interventions with AMR programs, is the most effective approach in order to deal with the quality improvement within the healthcare system. IPC interventions like hand hygiene is the most crucial and often provide a starting point for developing a culture of quality improvement in health facilities. But the problem is, despite of all this evidence which is gathering, only 50% of the countries report having a national IPC program or a plan or related guidelines. That is overall, when we are talking about the global scenario. But if it comes to the low medium income countries, it is even more alarming, where only 15% have a system to assess their compliance and effectiveness. So, but at the same time, fortunately, in the last few years, the socio-economic and also the behavioral sciences have played a good role and greatly contributed to the fight against healthcare associated infections by identifying barriers and facilitators for the implementation of infection prevention and control measures. um, you know Post COVID, now we all know that you all have actually experienced it, that now more and more we are tasked with increased visibility and also the accountability to meet the multitude of challenges affiliated with HIIs. It is no more, means when we talk about IP as a profession, it is no more a part-time or a shared position. It is a full-time job where it also involves actually us into patient safety and infection prevention improvement initiatives, antimicrobial stewardship, strategies for addressing new and emerging pathogens, and also possibly the future pandemics, the surveillance of infection prevention and control practices, the compliance with healthcare regulations. I can go on, but the point is the IPs, that is infection prevention, is tasked with more and more tasks in order to improve the healthcare system overall. Now, post COVID, now the question is the IPC momentum which has been built during this pandemic, will it be sustainable? And will the government and healthcare workers and other stakeholders prioritize evidence based infection prevention measures for improving quality care or not? That is what is to be seen. And during the next 5 sessions in this series, uh, the expert IPC practitioners who are on the ground would be bringing their perspectives, and they would be discussing in detail in order to understand how do we move ahead, how do we build evidence in order to have a proper infection prevention and control in our healthcare systems. So thank you very much for joining us, and I hope we are going to have a real festive season once again. Now, let me take the opportunity to introduce the today's eminent speaker, Dr. Nirav Pandya. Dr. Nirav, thank you very much. Despite of your illness, you have joined. Your enthusiasm is really contagious. Thank you. Thanks a ton for joining us today, despite all the difficulty. Now, introducing Dr. Nirav. Dr. Nirav Pandya is MD in microbiology, and he is certified in infection control from CBIC, that is United States of America. He is the clinical microbiologist and HOD Division of Microbiology and Molecular Testing of Dr. Udayan's laboratory, Vadodara. Dr. Nirav has also qualified in IDCC from PD Hinduja Hospital, Mumbai, CCIDC, ISCCM, and an infection control fellow course from IDSA, that is Infectious Disease Society of America. And he also has done several courses from London School of Hygiene and Preventive Medicine. He is a NABH and CAHO assessor with expertise in bacteriology, mycobacteriology, mycology, molecular testing, RT-PCR, etc., etc. He has numerous publications, both in international and also the national journals, with more than 712 citations for his published work. So, Dr. Nirav, thanks once again for joining us, and the floor is yours, Doctor. Dr. Nirav?
Yes, sir.
Yeah, floor is yours, doctor.
Achha, apologies, my video is not working for some reasons. But
No problem.
nevertheless, let's go ahead with the presentation. I would like to thank Dr. Ranga Reddy sir, IFCA and Simon for giving this opportunity to share my views on the topic. And so basically, this is Masterclass 5. So already most of the topics have already been covered in the previous four series. So this session I think would be more kind of brush up of this knowledge plus going one step further to utilize this previous knowledge we have gathered. So this topic are a bit different. Like today's topic is kind of prioritizing IPC practices. So we know the basics. We assume that we know the basics, and that's when we want to apply this knowledge to prioritize various practices in our setups. So that can. So let me start with my presentation.
Please, doctor.
Okay, is it visible? The screen is.
Yeah,
Okay, great. So
you
today's
can make it full screen.
just a second. Okay. So I'll be talking about these priorities for improving infection prevention and control. So this is theme is priorities and evidence practices for IPC. So I will be talking about priorities for the session. So I'm Dr. Nirav Pandya. I'm MD microbiology out in the CIC. I'm working as a clinical microbiologist and infection preventionist with various institutes. I've also done some of the courses like certified infection control fellow course in USA. I have been working experience for almost 11 years with various institutes like Max Hospital, Walcard, Bilodamin, and all that. So we'll be covering this topic under the three main headings: core component of IPC as described by WHO, high priority IPC areas, and lastly, implementing facility-specific IPC priorities. So going ahead with the core component of IPC, as we most of them are aware, what are the core component of IPC? The WHO have recently updated this guideline and given the 8 core component for any IPC program. Core component 1 IPC program, 2 IPC guideline, IPC training education, surveillance, multimodal strategies, monitoring, auditing, feedback, workload staffing, and other environment and equipment for the IPC. We'll just briefly cover up all these components. What is the basically salient feature of this component? So all these 8 components are basically part of this multimodal strategy. Includes IPC program, animal environment and core are the guidelines, education training, surveillance, and audit and feedback. But for all this, we require a good leadership from the infection prevention as well as the hospital side to lead this IPC program. Core component 1 is basically in what is says evidence. So evidence is showing that IPC program include dedicated and trained professionals are effective in reducing HI in acute care facilities. So evidence is there when IPC program is robust, professional are trained, it definitely reduces overall HI in the hospital. But it requires clearly defined objective functions, dedicated and trained IPC staff and multidisciplinary team. Support from facility leadership more crucial, and good quality microbiology laboratory to support these HI surveillance activities on that. So this is core component 1, which normally encompasses IPC program activities. Core component 2, it includes IPC guideline. Again, what WHO is concluded that evidence shows the guideline and implementation of this guideline actually reduces the risk of HAI for the patient. But again, for the expertise is required to prepare this guideline, we need to locally prioritize the area which we require to guideline and implement it. Provide resources for implementation like training material and what is required. Education and monitoring of implementation is required. So component 2 is the IPC guideline. IPC 3 is again this one step further than the IPC guideline. So we require IPC education and training. At facility level and national level, guidelines education should be promoted. Again, evidence show that IPC education involves frontline healthcare work in a practical and hands-on approach, incorporate individual experiences, is associated with reduced HI and increased hand hygiene compliance. So basically, they are the robust studies they have taken. Again, the training can be either pre-graduate, postgraduate, or in-service training. Evaluation of the training impact is required, and collaboration with local academic institutes is required. So with the very similar the training where series that is conducted by ICFI, just kind of one similar example of this collaboration between institutes. Core component 4, HI surveillance. Again, HI surveillance showed that lead to a decrease in HI plus timely feedback influence the implementation of effective IPC action. Most common example is the hand hygiene. Hand hygiene feedback timely should be given to the healthcare worker. For which we require standardized definition for HI surveillance, approved method, and good microbiology lab support and quality control of this laboratory setup required, plus training expertise in interpretation of HI definition. Core component 5. Basically, this is like a multimodal strategy. What it says, it implementing IPC activity at facility level using multimodal strategies. It effective to improve IPC practice and reduce HI. So, using multimodal strategy is one of the things which we require the multiple strategies. We don't need to follow a single strategy like training. We need to incorporate all the strategies. So first of all, it should be built it for any kind of change. We require the 5 steps. First, we will build the change. System should be there. We need proper guideline. Program should be there. We need to teach this change. Teach the training and education. Check what is the way guideline. Whether this training is actually fruitful to the ground level, or system is working. And sell it. We need to sell it means in kind of term marketing term, it's called sell it. You need to sell your product. You need to sell your policies or guideline. So for that, you need to use constant reminder and communication with the healthcare worker. It is not that once you educate and monitor, it will get implemented. You need to constantly remind them. And finally, leave it. So ultimately, what they work at, it becomes the culture, and everyone starts to leave the culture change. We are talking about the safety culture. So for this, we require multidisciplinary team. We require everyone for the infection control, for hospital management, from nursing staff to the HR person. We need all this for the implementation. And consider a range of strategies that target different influences of human behavior, like monitoring and feedback, infrastructure, organization, culture. That everything matters for the ultimate implementation of multimodal strategies. Component 6, monitoring and audit of IP's practice and feedback. Again, when you are doing regular monitoring and auditing of the IP's practice with the regular feedback, it increase the adherence to the practices, plus reducing overall HI rate. This is required to achieve behavior change or other process modification, and also to document progress and impact. You need to document it so that you know to what percentage you are on the right track or improvement is there. Core component staff 7. This is called crucial point: workload, staffing, and bed occupancy at facility level. What WHO says, bed occupancy exceeding the standard capacity will increase the risk of HI. And in addition, it inadequate healthcare worker staffing level. The standard for bed occupancy should be 1 patient per bed with adequate spacing between beds. So, like a minimum 1 meter bed spacing should be there. In pandemic, there were certain areas, certain hospital where the spacing was much of the issue. But this is a kind of rare scenario. This is a pandemic scenario. Otherwise, routinely there should be minimum 1 meter space between patient. And the staffing should be the matching with the overall capacity of the wards. This is important. This core component influences implementation of all other core components. So staffing, if staffing is deranged, it is going to definitely affect all the levels of the other component. Like in COVID, we know the staffing was a major issue. So we have seen this over IP's practice compliance was very less. Initial phase hand hygiene was higher due to fear, but apart from that, there was no compliance was very less. HI was higher increase in COVID patient. We also seen this mucormycosis increase. So this all staffing is the crucial point. And there are some WHO has given a wonderful technique. Like they given the WISN model, WINS model. So HR people can use this WINS model. This is available on the internet. There is one fraternity or forum is also there that guides the hospital to plan the healthcare worker requirement. This method also gives them some backup or cushion for the extra staff. They also prepare the hospital for the requirement of extra staff in case of emergency. So this method can be used to calculate the staffing requirement. And eight component: building a build environment, material and equipment IPC at facility level. Again, what we have to see, we have to make the equipment and product available at the point of care. Point of care, like we need to make the make available hand rub at the point bedside, at as near to the bedside as possible. It increases compliance. This is practical experience we all are aware of. Again, ready availability and optimal placement of hand hygiene material and equipment. It increases compliance and to the hand hygiene. Plus, appropriate cleaning and hygienic environment, wash services and material availability should be there for proper compliance to all the cleaning protocol and disinfection services. So these are the core components of IPC. Now, what we know these 8 core components for given the WHO. Now we have to select high priorities IPC area. Basically, there are plenty of core components, but we need to select high priorities. How can we select high priorities? So there are plenty of IPC practices are there, like surveillance, hepatitis B and C vaccination, realistic injury, community engagement, occupational health, media, policy wars, all practices are there. But we need to prioritize. Now, how we can prioritize, at least especially in our resource limited setting. So there was a study conducted by in the ACMID in 2016, in which they asked for all these their infection preventions to prioritize their in what their in side their opinion, their view on priorities of IPS area. What was the result was that on in European IPS preventionists, in their in their opinion, microbiology epidemiology or resistance is the highest priority. We are the similar kind of finding. Surveillance followed by decolonization, disinfection, antiseptic use, organism behavior changes. The fourth number, specific HKI as per in the setting, like we require some chemotherapy or the neutropenic, we require specific setup.
I'm sorry. Can you all please mute yourself so that Umachandran, Umachandran, Umachandran. Yeah, please.
Yes,
Thank you.
thank you, sir. Okay, so these are the top 7 priorities areas given as per the survey. Okay, normally economical, the initial points, initial 2 to 3, I think more relevant to us. But again, as I said, Europeans are normally they are very developed countries. Their priorities can be different. So what I feel is that we need certain 5 priorities as per our setup. That this kind of basic things we require: structured IPC program, hand hygiene, transmission-based precaution, bundle care approach, wash, disinfection, sterilization, HI surveillance, antibiotic stores. So these are the kind of 8 things priorities that for which pertinent to our Indian setup. So just briefly going these of these all 8 points require separate topic of separate lecture to address everything. But just not going to very depth and just going brushing up just on the superficially for all the important. I just giving you the important points of these points. Structural IPC program. What is the priority requirements? We require IPC program with a dedicated and trained IPC team in hospital, plus a functioning infection control committee, just not on a paper, but it's office HSL is functional. Whether it is meeting monthly or 3 monthly, it is not very important, but at least it should be there. It should be functioning, and someone should be the answerable. The IPC program should have clearly defined objective and annual work plan based on local epidemiology and priority areas. So we need to define the objective. If we want to improve our hand hygiene by 10% by the end of this year, so that is when we need to reduce our clepsy by 50% by the end of this year. This target or objective should be clearly defined. IPC policies, evidence-based guidelines should be developed and implemented. Again, this policy should be evidence-based, should be, I think, some good reference from either CDC or WHO, not any kind of opinion-based, but should be evidence-based. Like any of this, all these policies should be followed by IPC education training along with the new employee orientation or induction training, plus followed by the provision of continuous education opportunity at least yearly to all level of hospital staff, not only a nursing or particularly, but whether it is the healthcare manager or nursing doctor, at least annual training should be there. So these cover the all 3 core components of the WHO, the structure IPC program. Second, hand hygiene. Not going to very depth, but just what we need to emphasize is on the 5 component of WHO multimodal strategy for hand hygiene improvement. First of all, is the required system change. The alcohol-based hand rub should be available at the point of care. System change plus access to safe and continuous water supply or soap and towel. So either hand rub or water supply, soap and towel should be available. As in as we know, during last COVID, there are plenty of companies which pop up with the alcohol-based hand rub. As an infection preventionist, our duty is to ensure the quality of the hand rub product, so that we need compliance can be increased and it can be consistent. Plus, so the system chain availability of hand drum and supply chain and training educational staff, evaluation and feedback, hand hygiene audited and feedback, reminder in the workplace for 5 hours for hand hygiene and when to do the hand hygiene reminders, and ultimately lead to institutional safety and climates. So this is the safe for hand hygiene. At least this should be our priority. Transmission based, just a briefing. What I feel can normally there are plenty of contact precaution we are for COVID. We know, I think it is everyone is aware of the isolation precaution. But for Indian setup, for hospital setup, this contact precaution is very important, especially for the MDR bacteria. We have seen the plenty of cross transmission of bacteria in the ICU patient. So for the at least we should be able to give contact precaution for MDR patient having the MDR either infection or colonization. Patient can be kept in a single room or cohort with the same patient, like patient having the CRE Klebsiella. We can cohort them, or we can cohort the staff for them. Plus, so for the gloves and gowns should be required for the staff, not just cohorting of the patient or staff, so that they do not cross transmit the bacteria. Plus HIV, dysentery, we know droplet, H1N1, influenza, mumps, rubella, COVID, very droplet it could be aerosol spread. So single cohort patient, no required for negative pressure, airborne pulmonary TB, measles, chickenpox. Sorry for the spelling. And the single with negative pressure room is required with N95. So N95 is required for the airborne precaution, not for the droplet. Protective, all these neutropenic, immunocompromised patient, chemotherapy, AIDS patient, we require single room with positive pressures. So that we need to at least emphasize on at least some of the contact precaution area, make it a priority. So when there is no TB, no negative pressure room is available for TB, or what can be done if this setup is limited, no negative HEPA available, we can keep a makeshift arrangement like of making the room negative pressure by keeping an exhaust fan, so that air at least we can at least control the air direction. The air will be coming from outside, and he is the patient, air and it goes through out the window. So at least by another mean we can try to create some negative pressure or negative airflow. Now, bundle care approach. We know bundle is a kind of set of practices, evidence-based practices, which when grouped together give the better result than the single practice. The bundle care approach, why it is important? Direct benefits are shorter ICU stay, reduce financial cost, improve resource utilization, and it is very economical for resource poor setting to improve patient outcome and curtailing HAI. So bundle care, one of the great practices, one of the most cost-effective practices for the improving HI rate. So commonly, or at least basic, that should be followed of web bundle, collapse bundle, sepsis resuscitation or management bundle, more important for the ICU patient, potty prevention and SSI prevention bundle. So these bundle practices should be at least minimal. These should be implemented by the priority. Then wash. What is wash? So wash is basically a term coined by UNICEF. It is used for the water, sanitation, and hygiene. So these part is important for all for the community acquired infection in the community, as well as equally important in the hospital setup to maintain this wash proper. So for water, we need to ensure to give the proper drinking water to the patient as well as our staff. RO water, if you are using, it should be in comply with the the norms. DM water, when used for dialysis, it should be having the proper. You need to check it properly with endotoxin and culture and all the chemical parameters. For sanitation ID, we need to ensure proper cleaning of the areas, as it is been evident. Removing pathogen from high the surfaces is more likely to have impact on transmission than cleaning of inaccessible and low touch surfaces. So normally when we ask for the routine cleanings, the cleaning of high touch surfaces is enough. The deep cleaning for the inaccessible surface can be done in special case like after discharge of the infected patient. Otherwise, for routinely high touch surfaces cleaning is, I think, sufficient. Frequency of cleaning is still not, there is no standardized guideline available for frequency of cleaning, but we can define as per our protocol ICU, like we can go for 3 times or 4 times a day, ward every 2 times a day. But there is no clear evidence is available for at least to define the exact frequency for the cleaning. So we need to provide the standardized cleaning protocol for all the hospital area, different areas. And it should be followed universally, like preparation of proper dilution of what product should be used in which areas, and what is the contact time. That is our job to give them this protocol. Training protocol should be followed by training of the housekeeping staff for the proper follow of this protocol, and regular monitoring of any feedback. So cleaning efficacy monitoring should be done, mostly by the visual method or direct checklist. So what we can also prepare some kind this kind of checklist, like the monitor deep cleaning or terminal cleaning in ICU and ward. We can just point on a high touch surfaces, and then there's someone from the either housekeeping or supervisor can go to the area, check them visibly, and give the feedback to the staff immediately. And follow the fogging. There is one fogging is we all are aware fogging is now not that much not at all recommended. So there is a chronology of CDC recommendation for the fogging. In 2003, the guidelines were do not perform fogging for routine purpose in patient care area. 2008, the same was repeated, but again the category of recommendation was downgraded from 1B to category 2. 2011, there was guideline for the norovirus for the CDC. Again, they do not commit, and they just give the more research is required to clarify effectiveness of fogging to reduce norovirus contamination. So as you can see, the CDC has actually, in fact, they diluted their strongness of for recommendation against fogging. Initially, they are very strong against with the category 1B. Gradually, they come to category 2, and they finally get the no recommendation. But practically and theoretically, we can speaking, fogging can be done only for the patient with having the airborne infection. Like fogging, we need to do to clean the air. So, like patient the TB, influenza, not required that much unless aerosol is generated. Chickenpox, measles, and in special cases. And instead, we should be emphasizing more on the deep cleaning in routine for everywhere, whether it is OT or ICU, everywhere. Fogging is practically not recommended and not at all practically very useful. So better to emphasize deep cleaning and ask the staff to go for the deep cleaning in a more comprehensive way. Disinfection sterilization, just briefing on few of the important points. So we also need to define disinfection protocol for each reusable item and instrument, whether it is in the OT or in the ICU in the ward. We need to give them the protocol for how to disinfect the item. Either proper cleaning is required before autoclave, ET or high level disinfection. So what is normally the perception in the doctor's clinician's mind is that when you subject anything for ET or autoclave, it normally gets sterile. We don't need to do anything else, and we can do do all the items with the ETO. So we need to convey the message that the proper cleaning process is important. If the item cannot be cleaned properly, it cannot be made sterile properly. The item that cannot be cleaned should not be subjected to the ET or autoclave or a high level disinfection. The monitoring of sterilization process is also very crucial. Sterilization process we have seen normally there are multiple parameters can be used for the either physical testing, physical parameters, or the chemical indicators or biological indicator. The process monitoring is very important. We need to put this CSA person in charge for that to keep all this in chemical indicator in OT trace and do the use the biological indicator for the ETO items and autoclave. Also, need to define the reuse policy for at least for the setup having like cardiologist setup. Some of the areas like in the endoscopy area where this reuse is common. So we need to give the reuse policy. We have to define this number of reuse along with the consulting with our clinician friends. What the maximum number of reuse we can do, how to clean it, how to mark it, and how to trace it. So there's a point important for the disinfection and sterilization. HIS surveillance. HIS surveillance is basically it is our most high priority areas. So we also need to take the prioritization exercise to determine which HIS to target for surveillance according to local contexts. So we need to define our HI, which HI is more common in our setup. I need to target them. So the HI surveillance could either be facility wide, which we can be total and comprehensive, monitoring all patient care areas for all HIs, but it is extremely labor intensive. A useful approach for very small facility like 100 to 200 bedded hospital can be, but along we can be used for bigger hospital, but we require a large pool of infection control nurse for that staff for that. While targeted, the target are chosen as the risk of facility risk assessment, either unit based or infection based, require fewer resources. Like suppose we have seen our one ICU, Acinetobacter web is getting increased, so we need to target this web in this ICU. So we also need to can be target Acinetobacter for all the facility. Or we seek our in our hospital cardiothoracic surgery is high, so we need to target this area. This kind of surgery is high, these high risk areas. This is kind of targeted intra HS surveillance. Simplest form of surveillance is either if you don't have any resources at all, we can just start with the mortality or readmission rate after surgical procedure or after the ICU admission. Periodic point prevalence survey can be done to note the actual point prevalence of any kind of infection. We require train the person for surveys and pilot surveys to validate for the same protocol can be done. So when implementing some new protocol, like we are having some new product for the hand scrub, so we can do the pilot survey to validate this use, whether it is the effective or not. Type of HI, CDCs get more than 40 type of HI. We can don't need to monitor everything. Please web or VA event, web or VA event can be monitored. COTI, CLEPSI, surgical site infection, hospital acquired pneumonia, and others can be monitored. So, but we need to again follow this under this definition. Like CDC is getting we give the updated guidelines every January. We need to follow these guidelines for evidence base. Now, along with the surveillance, let's start the environmental surveillance, environmental culture. What are the normally guidelines say about surveillance cultures? So, category 1B recommendations are: do not conduct random or undirected microbiological sampling of air, water, and surfaces in the healthcare facility. So, it is against the routine surveillance. When indicated, conduct microbiology sampling as part of an epidemiologic investigation, only to for a kind of find out a kind of outbreak investigation. Limit microbiological service sampling for quality assurance purpose only, like monthly culture of water and dialysis and hemodialysis unit, and short-term evaluation of the impact of any infection control measures or change in infection control protocol. So for this, suppose we have changed some flow disinfection solution, so we can go for the some random or short-term surface culture for that to see this impact. So apart from there is no recommendation for regular like weekly or monthly OT cultures and all that. Otherwise, we need to we other. So the only exception if we are finding something specific thing. Antibiotic stewardship is really very priority area for our Indian setup. We cannot conclude without this. So normally, this all these trials the trial is their HAI surveillance of antibiotic resistance and antibiotic consumption and cumulative antibiogram hospital should be having the antibiogram cumulative antibiogram followed with the antibiotic policy and antibiotic stewardship program. So suppose what if hospital does not have this cumulative antibiogram? So recently, I think before a couple of last week only, ICMR has published the new last 2021 annual report. So we can take the support of these annual or local data and make antibiotic policy accordingly. So that's why if suppose if hospital does not have an actual proper antibiogram, then there is the way of way out of that. We can use this guideline. So 7 elements for the as a normally any antibiotic stewardship program. For any antibiotic stewardship program, we need leadership commitment from the leadership. Accountability, we need to appoint a leader or co-leader, either physician or pharmacist for the program management outcome. Pharmacy expertise is very critical. Clinical pharmacist appointment is a very useful, not more than useful, it is very helpful for the program. Action like implementing intervention, prospective audit and feedback is important. Action followed by tracking of this antibiotic prescription, intervention, and other outcome like CDF infection or resistant pattern. MDR or resistant pattern can be tracked. Reporting, regular reporting information antibiotic use to the prescriber. So we need to give feedback to the doctors for the better improvement. The continued education should be continued for all level of staff. So this core element is required for any antibiotic stewardship program. ASP common strategies, there are plenty of strategies which are not plenty, but few of the strategies are mentioned in the literature. The common that we can use is either prospective audit and feedback and formulary restriction. As per my experience, prospective audit and feedback is one of the excellent strategy that can be actually a very fruitful result. It is with a sustained result. Along with the formulary restriction can be clubbed with this prospective audit and feedback. This kind of list that we used to follow, so we used to restrict antibiotic like carapinam, higher and gram negative antibiotic, gram positive antifungal. So what we used to do is we follow this antibiotic formula restriction plus audit and feedback. So this is kind of very good strategy. We have good result. So in what we just what it incorporates normally give the right drug, right dose at the right time, right duration of patient. After antibiotic, wait for the 48 hours, see the result, and either stop, change, or oral switch the patient, or oral switch to the lower spectrum antibiotic, and continue reviewing. So we need to do this kind of continuous monitoring of the antibiotic usage. Surgical, again, we need to monitor surgeries that we should not skip out or miss out. The surgical prophylaxis should be at least given on this only single dose within 60 minutes before knife to the before incision. And we also need to incorporate one important point is if surgery is, I think, extending beyond 4 hours, or if blood loss is more than 1500 ml, the antibiotic dose should be repeated. So this point normally gets missed out in our antibiotic policy, but we can incorporate that. And finally, just few of the slides for how to implement all these high priorities in our facility specific priority to define these priorities. So what are the challenges? These core components all are there, but what are challenges that we face normally in our resource limited settings in our Indian setting scenario? So in India, we have kind of multiple kind of organization. We have a kind of two division. One kind of big corporate hospital, we don't have any resource limited. Plus one having this middle level hospital, or they have much kind of restrictions for the resources. So for them, we have limited access to qualified and trained IPC professional, limited human resources for the ICN and all the trained staff, inadequate budget for the dedicated budget for the infection control, implementation challenges for these practices. So we need to adapt and tailor to local cultural setting, local context, and according to available resources for that. Availability of training for the HR, human resources, quality microbiology laboratories support is required. And again, IT, these kind of one of the major area that we face. We don't have any kind of proper IT or data management system which help us in requirement for surveillance and auditing. There's some of the softwares are there, but they are very primitive stage. So we don't have proper good support of like CDC have this NHS system, but we don't have such kind of system in India. So we have to do all these things manually. It is very labor intensive. So how to setting up priorities in our hospital? So all the IPC program should be reviewed periodically, at least annually. And during this review, we need to set as well review our priorities. So we should plan to identify priority area of healthcare to be taken in phase manner, and also incorporate we need to target our priorities at the three terms: short term, 3 term what's a priority, medium term what's a priority, and long term what's a priority. The short term, like we can target like hand hygiene, we want to increase by 10% by vigorous training and feedback. Medium term, we want to improve our overall cleaning protocol and cleaning efficacy with the training and continuous monitoring. Long term, like year, we need to reduce our VAP rate for the overall period. So this kind of target or priorities we can set as plus in a phase manner. The program towards such goals can be monitored on a monthly basis. On infection control meeting, when we meet the infection control committee meeting in monthly, we need to monitor this progress toward this all the priorities. And setting clear priorities of measurement and improvement. We need to measure the clear priorities so that we can measure our improvement and the process. For that, to setting a priority, what the leaders of or leaders of the organization with infection prevention is should review external requirement as well as the internal measurement. Like priorities from external requirement like government regulation, accreditation requirement like NABH requirement, pollution control rules. We need to incorporate these as well. Plus, what are the internal requirement? Like include service, which are we need to target what the service we need to improve. Like, suppose we want to improve our surgical care, so the surgical should be in our priority. Medical staff concerns like some doctors are telling in our hospital or ICU hospital pneumonia is higher. The hospital pneumonia should be covered into the high priority. And clinical care that represent high risk or high volume services that warrant monitoring. There's a high volume service like one surgical surgery is high, so we need to target that. High risk. Suppose we have the high throughput dialysis center. So dialysis is our high priority areas. So once priorities are defined, the organization leaders then select the performance measures can begin. So we need to select performance measure, all quality indicators as per our priority areas. So the example of this kind of measure, hand hygiene applies using WHO tool. central line care and insertion, Foley's catheter insertion, surgical site prevention, MDR transmission monitoring and prevention, cleaning efficacy, disinfection, consumption of alcohol-based hand rub, and consumption of antibiotics. This is just kind of indicative list. We need to set such kind of indicative objective measurement to focus. So finally, for this, what we required? We required engagement of leadership, development of program and implementation of the areas in priority. For that, we require resources, assessment and strengthening, budget allocation, engagement to other healthcare work and bringing ownership of this all the processes, and identify the outcome indicators. So these from setting of the priorities, we need to how we need to measure the outcome by use of the outcome indicators. So for this, we required again, as I told you, multimodal strategy we require. So for we need to build the system change. We need to teach to the educator all this education, monitoring and feedback goes in the surveillance and monitoring or audit feedback, reminder and safety climate change where we need to leave it. So basically the IPS program. So these complete overall multimodal strategies for implementing success of our areas. Finally, concluding, few of the just perspective of so prioritization is the key in resource limited setting. But we need to convince the leadership that resource invested in IPC are worth the net gain, irrespective of the context and despite the cost incurred. Whatever you invest, it kind of pays you in the long run. Not all solutions require additional resources, and some of the solutions are very low cost that can be implemented readily. Like if it is not feasible, we need to collaborate for the better achievement of the core component delivery and funding. And again, policies are there, everything is there, but implementation is the key. We need to our job is to transform policy to practice. It is not always easy and time consuming. We need to prioritize and go over the stepwise. Multimodal, multidisciplinary strategies are required. We need to devise our policy and people centric, integrated with clinical procedure. An innovative solution can be think of for the better implementation. Okay, thanks a lot everyone for listening. I'm open for the questions. Thanks.
Thank you very much, Dr. Nirav, for that very comprehensive presentation, which has probably covered 360 degree of IPC. You know, especially your concluding slide is very, very important in terms of emphasizing on the fact that implementation is the key. We have so many guidelines now available, both from the World Health Organization, CDC, various other organizations, including our NCDC, ICMR, etc., etc. So policies are there. Probably now we know, from what you mentioned in your presentation also. By now we know what are the priority areas. We have adequate probably knowledge. I'm not talking about actually experience, but the knowledge on what are the priority areas, how to probably go about them, what are the requirements, etc., etc. I think you have covered very beautifully all those things. A very, very informative presentation. And one more thing, probably I would like to emphasize once again what you said in terms of the outcome indicators. At the end of the day, anything what we do, it had to have the right kind of outcome, which is very important, for us, because we need to get that satisfaction of doing something and also seeing the outcomes of whatever we are doing. That is one part of it. Two, to also build the enthusiasm in the team, among all the healthcare workers. And third, probably is also to showcase to the management that there could be a realistic kind of outcomes which are going to enhance the quality system or the quality kind of outcomes, which is going to probably help the management also to take proper decisions in terms of investments, in terms of actually the people deployment, other resource deployment, etc., etc. A wonderful presentation. Thank you, Dr. Nirav. I think I'm just looking at if there are any questions in the chat box. Uh, I don't see them. If any of you have got any questions, please raise your hand, and then or you can put them into the chat box so that we can request Dr. Nirav to uh, bring further perspectives into those areas. I see a couple of them in queue. Just let me see. Are there anyone who want to ask any question? You can unmute yourself and ask the question or post it in the chat box. Okay. Okay, great. I think there are no questions. That means there are two things: either they understood everything
Hello.
or they haven't understood anything.
Sir, Dr.
Yes, Dr. Burri, please go ahead.
Hello.
Please go ahead.
Please go ahead.
Sir, I just wanted to know about the fumigation of critical areas like ICUs.
Okay. Just basically fumigation or fogging is not much recommended for any kind of critical areas, whether it is OT or ICU. Unless you are having the patient of tuberculosis and getting discharged, so you may think of go for fogging for that. Or second is if your ICU is getting out of this construction, you suspect there can be fungal spore in the air. So in that case, you can go for the fogging for that. Plus, then make sure that fogging is it should be it should be deep cleaning should be there before going for the fogging. So deep cleaning and fogging should be go together when you go for fogging. It is very limited setting. Like if you are having the tuberculosis or aspergillosis, you have multiple patients with aspergillus in the outbreak is there. You are having this construction activities going on and it's getting over. Apart from there, I don't see any rationale for the fogging in any other areas, in the ICU especially.
Thank you, sir.
Yeah.
Sure. I see two more hands raising. Chintu Kalpana, please go ahead, madam. Kalpana, please go ahead with your question. Unmute yourself and ask the question. Okay. I think Dr. Anamika Vyas, you have raised the hand. Please go ahead with your question.
Good afternoon, sir. Doctor, you just said that fogging can be done when the renovation somewhere in ICUs or OTs, or in case if a TB patient is getting discharged. So, sir, my query is that routinely should we go for fogging the tuberculosis IPDs where they are having some open cases?
Couldn't hear it properly, but what I understood, normally you are asking about discharge of the tuberculosis patient, right? Okay. So what can be done? Can normally what tuberculosis open cox patient, not for the routine TB patient. For open cox patient is there, we need to follow negative pressure is to be there. Negative pressure is not that we need to before taking another patient to his air is clean. TB is airborne, right? We need to disinfect the air as well for that. So for fogging, at least I recommend to go for the fogging is required.
Doctor, one more question, coming from Anand Janagon. Again, the same question. Is fogging recommended for OTs periodically for wards admitting TB patients? I think, you answered. Maybe, you can emphasize once again. I think
Yes.
it is a question, many people have in mind.
Yes. The fogging is kind of one when surgeons are, I think, after life of microbiology, to go for the fogging. Why don't you recommend fogging? So we need to take our calm ground. If deep cleaning is proper, no required for any kind of fogging. The only exception is when you are having this airborne infection.
Absolutely. One more from Dr. Anamika Vyas. targeted surveillance. Can you elaborate a little more?
Right. The targeted surveillance of what targeted means, what I mean was we need to go for risk assessment. Risk assessment about various areas. So right now there is one or two guidelines are available from the CCC in which they give the interest control assessment tool. So you can use this guideline, go for our risk assessment. You can define your priorities and area and high risk activity. Like suppose your hospital is admitting more kind of more ICU capacity, more surgical ICU. So you can target some areas like second-part infection in the surgical patients. So we need to define our targets. Whether we want to conduct audit in this kind of particular area or ICU or particular activity. So you need to go for the risk assessment plus your previous year data. Place, and you can go for all these documentation review. You see your last year data. You see that your fertility is high in one ICU. So you can target the surveillance for this ICU at the 40.
Maybe one last question we would take from Auden Vitas. She is asking fogging or UV, which is better method of disinfection for OT?
Just a second, my voice is I think echoing.
Yes, fogging or ultraviolet, which is better method of disinfection? That is what is the question from Auden.
Hello.
Can you hear, Dr. Nirav?
Am I audible now?
Yeah, there is a question. Yeah, there is a question between fogging and UV, which is the better method of disinfection for OT, operation theater?
Fogging or OT? That's a fogging and UV light. Okay, that's an interesting question.
UV, yeah.
Normally, I think for UV, basically it is one is kind of outdated. Fogging is kind of not getting outdated, while one is actually very new. I recently don't have any robust studies for the UV light. So UV light.
Excuse me, sir.
Yes.
Actually, the voice is breaking, sir. It is echoing, sir. We can't hear the answers properly.
Just a second. Hello.
Okay.
Just a second. Hello. Hello.
Yes, doctor, go ahead.
Yes, am I audible now? Clearly or echoing?
Yes. If you could speak from the mic a little nearer to the mic, probably that would be
Okay. So basically, as I was telling, there is one fogging and UV light is kind of two different modalities. Fogging is not a very outdated method right now for everything. While UV is kind of much newer. We don't have any much recommendation or much evidence for the UV light. So
yeah, especially for OT, I think the guidelines or the available evidence for the UV in OT, it is very limited. But yes, I think it has got its own place. I'm sure as the evidence is going to gather, probably it could become an alternate to obsolete process called as fogging. I think that is what probably is the answer to that question. Do you agree, Doctor Nirav?
Agree, sir. But agree, sir. Normally, the problem with UV light is that we need to ensure it is all the areas. So for this logistic or practical issue is there for its implementation. But technical it is excellent. Just too early for implementation.
Sure. Thank you very much, Dr. Nirav. Thank you, all the friends. If you still have more questions, please write to us. We are going to have as a conclusion to this series a panel discussion, which is going to be moderated by Professor Shamana. So all those questions, which are not being answered, or you would get further questions, you can keep posting to us, and we will try and get all the answers possible through the great panelists, expert panelists, who are going to participate in the last. And please ensure that you are going to attend to all the 5 sessions so that you can get your certificate. And please ensure that you are going to join in time and keep your mics muted so that everybody can enjoy the academic feast which is being actually given by the expert speakers here. Once again, thank you very much to all of you who have joined today for this very interesting session, which was delivered by Dr. Pandya. And we look forward to see you again next Tuesday at 3:30. Thank you.
Thanks a lot.
Thank you, sir.
Thank you, sir. Thank you very much, sir.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you.